We've got a lot of our friends assembled here, a lot of people who are implementing this great technology found in interventional glaucoma, but also some folks who will be on the line who haven't. And so we're going to get started and get underway just for the sake of time. I want to first say or tell everybody why we're doing these calls. So we're calling it Third Thursday. We're calling it Third Thursday because magically it's held on the third Thursday of every month at 3 because alliteration and repetition seem to help remember things. And it's really time that's set aside to help practices know how to implement IG strategies. Now, we've got friends in industry who are working hard to create new technologies all the time to help patients slow the progression or even stop the progression of glaucoma. And we know, and we'll talk about it here in a moment, that drop therapies as a first line defense aren't doing the job that they should, mostly because of patient compliance, but also because of adherence, because of pain or side effects or cost. And so it's really up to us at the practice to figure out other ways to make sure that those patients are truly under management. And so we'll cover some of those things in our session today. But today, after those industry friends of ours have gone to practices and alerted them or wakened them to, that there is something we need to do differently for patients, a lot of practices then ask the next question. Okay, I believe. Now what do I do? And so this is a clearinghouse for all of us to come together to say, okay, now that I believe that we need to be more interventionally minded, what should I do in my practice? And so there's administrators here. There's doctors will be on the call. There'll be some industry folks here. But every third Thursday of the month, we're going to be talking how to implement technologies and being more interventional at the point of care. Now, today we're going to be talking about the importance of the phone call, which is the first step of the customer experience cycle. And you'll hear a little bit more about what I mean by that in the first place. But I want to just stress to you that I think that the phone call is one of the most important pieces of a satisfied and educated patient. And it's frankly, it's the most underutilized tool that we have as leaders of the practice. Now, though I haven't introduced myself, a lot of you are friends. So I'm Matt Jensen. This is how to reach me afterwards or during this conversation. If you've got questions, or you can unmute and interrupt me, or you can text me or email me things that we should be talking about on this session. For the first few sessions over the coming months, we're going to be talking about specifically each step in the patient's life cycle within a practice before we start customizing it to your feedback and needs. And a lot of you I'm going to see next week at the ASCRS and the Business of Interventional Glaucoma course, which will also affect some of the curriculum that we continue to talk about here. So Margin is the company that's putting this content on. That's my consulting arm of a company. We've got a marketing arm called MJM. And for 20 years, I was the CEO of Vance Thompson Vision. So between promote, kind of the two lives that I live in all the time. And that's why that little graphic was there, is because we're trying to create space to create tools and place them in space for growth. Now, the first thing we're talking about today, as mentioned, is what we're going to supply the team with, or what we should be supplying the team with by way of tools and training. And it's just one of the things that we need to have to talk about this ever-changing category within glaucoma. Now, interventional glaucoma, the first thing that we can find, and this is industries and our team of researchers, the first time it was in a publication was in 2015, although people believe that it was coined in conversation at least 18 months prior to that. And these are some of those early conversations about it. And everybody believes that drops are not a great first-line therapy, though they can be a bridge therapy between interventions. They're not a great first step. Now, a lot of people then say, okay, so after 10 years, how good are we? Certainly, we should have adopted some things by now. But when OD referrals come in, or from the patient, earned. Our intervention levels are at 25% or below, and you can see how the numbers shake out, lasers being the leading interventional therapy, but others within that. So we've got a long way to go to make things other than drops a first-line therapy. And we know that while drops have great chemistry, you don't have to work very hard before you can find citations that show how compliance, adverse events, redness, sinking of fatty tissue, price and all those things really working against us. And at best, we think compliance is around 50%. And at worst, it's much, much lower. And so to say that we're managing glaucoma patients through glaucoma drops is to say we're not really managing patients. That's the assertion. And we can say that from the admin standpoint because we're not, we haven't taken the oath of really wanting to be mindful of our commitment to patients, but we can just look at the data and say whether or not we're being truly interventional. So our thesis is this at Margin: it's that drops alone does not equal management. Surgery is an ethical first step. And because of the environment that we're currently in, there's a lot of interventions that can be profitable as well. And so in an environment where reimbursement is declining, and patients are in great need because their disease is progressing, this is a great way for us to follow up on our doctor's oath to do the right thing, but also for us to help the health of our overall practice. And that's what we're talking about today. A lot of doctors came to Southern California to put together a consensus treatment protocol on how patients should progress in their interventions or could, to try to invite more doctors to participate in the management of this care. And that's become a source document in all of our conversations. And so for those of you who have providers, please reach out for this document, because I think it's a good way to get us all on the same page, much like the DEWS study did for dry eye, to give us all kind of a roadmap of what interventions should take place, perhaps in what order, and especially if I'm not familiar with managing glaucoma as much as maybe a glaucoma specialist would. Okay, so that's our little intro. Back to our topic at hand. And so for the first couple of minutes here, I'm just going to go through what we think the importance is of how we train. And if you know anything about our firm or our practices, we believe the customer experience cycle is the best way to implement any new technology, that we're going to take morsels of it and we're going to customize it for the phone team, for the people testing us and doing diagnostics, for the folks who are doing reading. We're going to spread out the work across the whole continuum and not just count on that time with the doctor in the consult down here in the bottom center. That we're going to spread out that work so patients have a fighting chance of remembering how and why we're recommending what we are. And that's why today we're talking about the phone as the first step in that process. So first of all, you all know this because you're great practice leaders, but it's worth reminding. And for those of you who have new managers, listen, the most important tips for phone skills, really in any category, is to remind people that, oh, you've called the right place. If you're calling a doctor's office, usually it's with some level of anxiety or to alleviate something, and we want to reward them and play to their emotions by saying how they've called the right place. So emphasize empathy, acknowledge their frustration in this category, perhaps with drops. Remind us to use simple language and avoid technical jargon, and then start to begin to position interventional glaucoma as an option that a patient might hear about during an exam. And that has to happen way back at that phone interaction. Listen, if we're starting to talk about the importance of interventional glaucoma way back here on the phone call, then when that patient is finally in front of the doctor, they will hopefully have heard it several times that this is going to be something that they're going to learn more about as part of their care. And we know that adoption will stay high if that's the case. So those are some tried and true methods to have in front of your phone team. So this is just a sample script that we've created. There's many like it, but I think in an ideal world, this would be what we would empower a phone team member, a phone team manager, to train their team on. So forgive me for being so didactic here, but we're going to just read this word for word because I think you'll agree I think you'll agree it's a good, it's a hopeful way to talk about this category. So ring, 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 ring. Thank you for calling Clearview Eye Specialist. This is Sarah. How can I help you today? Yeah, I'd like to schedule an appointment to get my glaucoma checked. Absolutely. Well, we'd be glad to get you scheduled for a glaucoma evaluation. Just to confirm, have you seen one of our doctors before, or would this be your first visit with us? It's my first time. Well, great. Welcome. And you have called the right place. We'll take good care of you. Now, our glaucoma evaluations are very thorough, and depending on your needs, our providers may also talk with you about some newer options that go beyond just daily eye drops. Have you been managing your glaucoma with drops up to this point? Yeah, and honestly, I'm pretty tired of them. They sting, and I keep forgetting to take them. Well, you're definitely not alone there. A lot of patients feel that way, and it's part of why we've introduced a more interventional glaucoma therapy. They're designed to help reduce or even eliminate your need for drops in some cases. So we want to teach you about those things. But what kind of treatments are those? Well, that's a great question. The doctor's going to go over a lot of the details during your exam, but just to give you a quick preview, some patients qualify for a minimally invasive glaucoma procedure. Others may be good candidates for laser treatments. We also work with some technologies like sustained release medications that are applied in the office or in the OR and can last months or even years. But the goal is to protect your vision and get you stabilized while making your life easier. Well, that sounds really interesting. Is it covered by insurance? Well, that really depends on the type of treatment and your specific plan, but many of these procedures are covered. And by covered, I mean insurance will pay a portion of your charge, especially when they're used to manage pressure or combined with cataract surgery in general. And you can see the script goes forward from there. But can you imagine if each of our patients came in with this level of education before ever walking through the front door, that they know that they're going to be learning about some of these new options? Perhaps that's supplemented with what we're going to talk about next call, which is what happens between the phone call in the customer experience cycle and when they come into our office for the entry or greet. We call it pre-service. You know, if we were to send them a piece of literature or a link to a video or a link to a spot on our website that talks about different interventions. And so just like in the world of laser vision correction or cataract vision correction with refractive options, we're educating our patients in a very similar fashion. So they're predisposed to want to treat their vision properly as part of their visit with us. Once we have training like that, then we need to make sure, of course, that it's managed across all of the different patient types, and it's really that scripting that empowers your team. We answered some of the common questions. Almost always the first question is going to be, is insurance going to pay for it? But you saw I was really mindful to say that insurance will cover it. Well, they'll cover a portion of it, because a lot of insurances today may not cover all of it, and we want to make sure that they still understand there's a likelihood they're still going to have a responsibility to pay their co-insurance, co-pay, deductible, et cetera, depending on their plan, federal or otherwise. So that's just a few tips that you have to think about when it comes to patient phone scripting for your team. And of course, you'll have to train team members on your scheduling protocols and elements like that as well. So, okay. So now that's kind of the backdrop, is that a good practice who wants to be more interventional needs to have some things like phone scripting. But we've got real leaders on the call today. And I just wanted to open up the phones to figure out how you handle this in your practices. And also, what tools don't you have that you wish you had in your practices to make this even better for your team? Anybody dare to unmute?
Hey, Matt, Arsen Gregorian. Yeah, happy to share some of our thoughts. And I agree with you. Our call center, or the department, we actually renamed them as the Patient Support Center, they are a critical part of our company's success. I've actually gone as far as to name them. This is more of an enduring term that we use internally only, but I actually call them the voice of Harvard Eye, because I want our team members to know that when the patient calls us, they're the first voice that they hear, and they're the greatest ambassador for our organization. So even before the patient steps a foot into our organization, we're already leaving a strong impression on them. And so I think by having them understand that they're the voice of the company goes a long way. I think the challenges that I'm sure a lot of organizations have been having, and it's not, we're not immune to it either, although we're finding solutions for it, is having the manpower in order to ensure that we can educate the patient sufficiently. Oftentimes with the call center, especially when you have a large volume of calls coming in, the agents are tempted to try and cut corners, to try and get through that booking, to get on to the next one, because they're caught between a rock and a hard place. Because if they spend too much time with one patient, then the number of patients in queue gets longer, and then the next patient you pick up is going to be more upset. So it's going to be even more difficult to pre-educate them. So the way that we're working around this, short of just throwing more dollars towards this as a solution, is we're actually looking at creative solutions of outsourcing. For the longest time, I was against it, and then I looked at some practices who had done it successfully, and essentially we are able to tap into folks over in the Philippines who, although they're about 8 hours separated from us, depending on what zone you're in, we found that there's a U.S. ecosystem there that works very well. And their work ethic, quite frankly, competes with our U.S. agents. So we had a beautiful success story whereby we outsourced one individual at a fraction of the cost. And this agent, within 4 weeks, ended up becoming our top 4 agent, which is saying a lot to do in such a short period of time. And when we speak with her, she doesn't have an accent. You can't even tell that she's from the Philippines. And her work ethic is impeccable. There's a difference between somebody truly feeling unwell and not coming to work versus what I call the tummy ache. They have a tummy ache and they choose not to come in. So with these folks wanting to work instead of that mindset of having to work, or why should I work? They are more honor bound to do a better job. And we've seen that quality manifest. So I think by being able to outsource more, what we would be doing is giving our call center the tool and the time and the resources in which to execute and implement these types of approaches, which I think is ultimately—
That's what I wanted to ask you, Arsen, and sorry to interrupt, but so then do you empower this team with scripting like this? Because we've worked with outsourcing groups depending on the practices we're consulting for, or been tempted to with some of the practices that I literally was the CEO for, and we at least at the time didn't have the presence of mind to go into this level of specificity in disease state offerings. Now we did when it came to things like refractive cataract surgery and laser vision correction, right? But for whatever reason, when it came to a disease state patient, we're just like, just book them, just get them in front of our doctors, and we'll move on to the next one. And I think it's a different time now because there's so many options. It's really best for the patient. It's going to be more streamlined for the practice because they're going to be more likely to adopt a technology. By the way, we might not have to see them every 45 days as well because we're managing their pressures more consistently with these technologies, says the literature, not the consultant. And then it can also be, profitable for the bottom line of the practice. Are you able to get that level of specialization?
Good question. Yeah, we haven't yet, but I think it's about time for us to do that. As you mentioned, I think cataracts, other things that have been a lot more profitable, a lot more top of mind, we've done that for. But for interventional glaucoma, I think we're guilty of not doing enough. But anytime I ask my team members to do more, I always want to give them more time. So now that we kind of bought them that more time through those more resources, it's bound time for us to ask them to be more engaged as this process is concerned.
Yeah, and I'll bet they'll be like, it's amazing how well people respond if you just ask them, but they probably don't know because, we're just learning that this is important. What about others who are running practices? Have you engaged your frontline team members to be able to have conversations that are, maybe a higher level of sophistication like this? I see you, Ben Seals, or your knee anyway.
Hey everybody. I didn't realize my video was on. Thanks for calling that out, Matt. Yeah, I would say this has been a great call out of something that we missed in our implementation, and I love it. And I appreciate you bringing it to my attention that we need to do a better job training our frontline folks. We trained our clinic folks, we trained our ODs, we trained billing team, but we missed the voice of the the practice. So, yeah, I'll fall on the sword on that one. That was a miss on my end.
Listen, all that is all of us. That's why we're doing this, is we all can learn from one another. And we'll get into the, how we do that in other categories here in a moment as well. I appreciate you tuning in to say that, though. How about Melissa or Chris or Ashton? Any comments from all of you?
Go ahead, Melissa.
I was just going to say, I'm a refractive practice by nature. We've been refractive practice for 20 years. All we do is premium IOL and LASIK. And so when we started interventional glaucoma, that was actually the first thing that we thought is, well, this patient is going to call in, and the first person that talks to this patient, they have to tell that patient, and they have to make that patient feel as though we are the only place that they need to come for their glaucoma care. Because yes, they can go down the street, sure, but they're not going to get as great of care as they would if they were here with us. And so we equip our front staff and anybody who is on the phones. We cross-train. We have our technicians handle a lot of the calls if it gets more into the weeds clinic wise, but there's essentially two groups that are calling in. There's the group that, they've been on glaucoma drops. They've been referred in by their doctor. They know they've got glaucoma. It's all gloom and doom and drops forever. And then there's the other subset of patients where they just had their eyeglasses checked and somebody said something about high pressures and they heard the word glaucoma and now they're kind of freaked out. Right. And so the underlying theme that we have to make sure that our phone staff and everyone is talking about is hope. Hey, so we've got these incredible options. I know you've been on drops for years, but did you know that there's actually ways that we could potentially reduce your need for that? And you should hear the way that it changes the patient's tone. They're like, wait a minute, I'm sorry, I was today years old when I heard about that. This is real news. And then for the other side of things, the patients that are, completely freaked out, yes, it's okay. We've got you. Our doctors specialize in this. We're going to do a battery of tests on you when you come in. We'll figure it out, and then we'll make a plan together. So they're literally the first touch point. They are the voice of the practice, really. So from a refractive perspective, when we started implementing interventional glaucoma, that was one of the first things that we did was make sure that we trained them up.
That's great. And good job on that. It's likely because you were so refractive heavy to begin with that gave you the mindset to do that, right? Because that's the only reason. I mean, that's how we created the customer experience cycle in the first place. But it's really easy to forget, to circle back to the folks who are spending the most time with the patients, which is what these sessions are about. Ashton, how about you?
Yeah, so I feel like I kind of toe the line here between Ben and Melissa and Arsen. So our practice, we have definitely not scripted the way you have. And I literally was taking pictures of your slides and sending it to my office managers as you were reading it. But no, our front desk is definitely so we have pretty high expectations that everybody's pretty cross-trained. So they know how to do testing. They know how to talk to most of our patients who call in. They got the same interventional training that my techs got. So they know, depending on the patient, depending on the concern that the patient has, they know the providers that they need to put them with. They all talk about, they have, I think it's 3 times that they have to mention the provider's name, and they talk about oh yeah. So Dr. Chris Spearman is one of my doctors. He's the doc on here, but they know yeah. So he's my partner in crime. So yes, he absolutely had to join, but they know when they answer a patient who's calling in for their glaucoma, they're very much trained to say, oh my goodness, Dr. Spearman is great. You're going to love him. He's going to take a very, very personal approach to figure out how to best treat your glaucoma. So we don't go quite into the weeds of talking about interventional glaucoma, but they do very much try to relate to that patient on their level. And again, just reassure that we're going to do everything we can to get them taken care of as best as we can.
Yeah, I love that. And listen, all these slides can be afforded you, so no need to take photos.
I love that.
To all the attendees afterwards. There's no pride of authorship here. This is precisely what we're trying to do here is spread the word and steal shamelessly, and then also offer feedback on what we can do better in the future. Dr. Spearman, I'd love to hear from you as the inaugural doctor.
Woohoo!
Welcome to Third Thursdays. My goodness.
Come on.
Any comments from Dr. Spearman?
Sorry, can you hear me?
No, yeah, we can now.
I was just hopping in the car and switching back and forth from Bluetooth to speaker and whatnot. So, yeah, I mean, I'm just taking a lot of feedback from you guys as we're going through this. I think, this has been a thing that we've been pushing for quite some time, but really taking a whole next step initiative over the last 6 months or so. And so I think all of these extra pointers about how we can, have a uniform message to the patients about really the best way to treat their glaucoma. And when it comes from every single patient or every single staff member, from, like you guys said, front desk and call service, through the technicians, through the doctors, that same uniform message helps drive home that this really is the best way to treat their glaucoma, and really takes a lot of the kind of second guessing and anxiety away from the patient.
It's really good the way you said that, because I think that whether it is refractive cataract or whether it is glaucoma or anything else insurance related, pretty soon it'll be, cross-linking with some new technology. There will always be something new. And internally, we have to have a way to communicate it where everybody gets it. And I just think of my upbringing in the restaurant industry. 86, the pork, at the middle of the night means we don't have any more. We don't have any more until we get it kind of aged and rebrined and whatever in a couple of weeks. So, but mid shift, there's a way for everybody to communicate. And same thing should happen with our visit types. A patient is coming in for refractive cataract. There's a downstream expectation of how we're going to communicate with that patient. Same thing with interventional glaucoma. And that can only happen if we're communicating with our team. P.S. They really want to act to this level too. They're in awe of the doctors and how specialized they can be, and they find themselves loving their work and themselves in the work the most when they are doing it at this very, very high level. And so I believe that the front line is a key place to start that discussion. Listen, this is what these sessions are about. I want to just thank you guys for tuning in to this. I know some of you I invited personally, some of you registered normally, but listen, we're going to have this at least every month and use it to help practices implement new technologies. Here's our next topic. We're going to talk about pre-education, and that'll be May 15th, the third Thursday of May. And then for all of you, I think all of you know about this, and most of you are in attendance. The Business of Interventional Glaucoma is 1 week from today. Literally right now, we will all be together next week at the same time as we're launching how to train people on tactics like this. Please reach out to me with ideas and out to us. I want to thank Courtney and Rachel from our team for pulling these sessions together. I think we're going to learn a lot together, and we're just getting started. Thanks, everybody.
Thanks so much.
Thanks, Matt. Appreciate the invite.
Matt.
Have a great night, guys.